Hi everyone, I'm Kathleen Warshawsky and welcome to DAGS. We have a great program for you today and I'm so glad that everyone was able to make it here via our Zoom technology. This is our first DAGS virtual webinar and I think that we're going to be seeing some more of these. So thank you all for being here and for attending and really appreciate it. For those of you who are new to DAGS, DAGS is the Dallas Area Gerontological Society. We are a group of volunteers and we raise money for scholarships. We provide educational programs and we provide advocacy for older adults. And we are made up of a board of volunteers, and it's really hard for me to give a shout out to every single one of them right now, but I think for our next call or our next webinar, I'll put a list of our board members up there so that you can all see them. We do have one that's probably on your screen right now as one of our hosts here, and that is our Vice President, Miss Susan Rogers, so she'll wave at you. And I'm Kathleen Warshawsky, and I am the President of DAGS. So we welcome you all, and we're so glad that you're here to join us. So our hosting community today is Wellbridge Healthcare, and we have Miss Christy Argo here from Wellbridge, and she is going to tell us a little bit about Wellbridge and also to introduce to us our speakers.
Absolutely. Thank you, Kathleen, and thank you, DAGS, for allowing Wellbridge to be the host with the most today. We're so excited. We have a great topic for y'all on geriatric mental illness and social distancing. But first, just to share with you briefly, Wellbridge is an inpatient, outpatient behavioral health hospital treating ages 50 and up for those suffering from everything from anxiety, depression, trauma, self-harm, social challenges, behavioral problems to the extreme of suicide and addiction, especially during these tough times of COVID and the grief and the separation. You know, we hope to have been just a stable entity for those that just truly need the help. And we're always available 24/7. And just remember, mental health and addiction does not take a holiday, neither do we. We are open over Memorial Day weekend. So without further ado, I would like to introduce you guys to the speakers today. You're in for a treat. It is our outpatient team. Our outpatient manager is Monica Nystrom, and our outpatient therapist is Kaitlynn Griffin. Ladies, take it away.
Hi, again, my name is Monica Nystrom. I'm the outpatient manager for Wellbridge. And so if you want to do the next slide, that would be great. So I get started. So I want to mention that this slide is the only slide that we actually have research statistics on. The rest of the slides we did through experience and what we've seen in our program. As you can see, that the older population is going to grow. According to the US Census, in 2015, the population of 65 and older was at 47 million, and is expected to grow to 98 million by 2060. And so the older population is just getting larger and larger, and so the mental health issues are going to get larger and larger as well. 80% of the older adults are living in long-term care facilities, and they suffer from psychiatric diagnosis or behavioral changes. And I want to mention that specifically because that's a lot of who we work with in our program. We work with a lot of the population that are in nursing homes. And so it's important to know that a lot of those individuals are suffering from a mental health issue. Next slide, please. So when we talk about older adults, we talk about 50 years and older. Most of the patients that we work with in our program are 50 years and older. Some of them are working, some of them are retired, and majority of them are in nursing homes or long-term care facilities. Again, we work mainly with the retired folks and then the folks in the nursing homes. Older adults are living longer due to the advances in medical care these days. When I was doing the research for the statistics, I noticed there really weren't a lot of research regarding older adults and mental health. I think that might be due to, there might be a possible stigma with that. I've heard before sadly, I've heard before from other people that depression is normal in older adults, or, they may have mental health issues because their quality of life isn't supposed to get better. So there might be a possible stigma behind that. We're here to kind of let you guys know that there is treatment out there for the older adults. What type of treatment there are, we'll talk more in detail about, like individual and group therapy, but there are places like us, like Wellbridge, that serve the older population with mental health problems. There's home health resources out there, and then there's also support groups out there for the older adults that are struggling with mental health. So part of it is trying to, or is to identify when there is a need. We'll talk more about this as well. But what mental health looks like in older adults, identify who is in need for it. And what we mean by that is not, oftentimes, the older adult, when we get phone calls, may not think that they need help, or they don't want to do it. But mental health doesn't just affect the person that's struggling, it affects the caregivers and family members. And so we want everyone to know that there's help for them as well. And so, it's a matter of identifying who needs the help. Next slide, please.
All right, so I'm Kaitlynn Griffin. I'm the IOP therapist here and also the pet therapist as well. I didn't bring my pet dog today, but I was thinking about it, but she's at the doctor, so. Anyway, so what we see here is very similar to adults. So mental health does not discriminate. It really doesn't. So we see a lot of mood disorders. A lot of the things we see typically are like depression, a lot of anxiety lately. Sometimes we even see some like borderline and some bipolar. Suicidal ideation, we're going to talk about in just a minute. It's kind of different depending on what's going on, if they're going to come to outpatient or if they're going to go inpatient first. Sometimes here we might sit here and start out as a outpatient referral and have to send them into inpatient just to make sure they're getting some type of medication management and we're really reducing their suicidal thoughts and things like that before we go ahead and bring them in to our outpatient program, because we just want to make sure we're doing what's best for them. Substance abuse has also been on the rise. We've seen that a lot lately, and I know just today we got a couple more referrals just for alcohol use and even opioid use now, and so that's been really increasing as well. And then neurological disorders, a lot of them still do have audiovisual hallucinations. They have paranoid ideation. They're struggling because of just everything that's going on. It's kind of like being in a room that's you're isolated and you're by yourself and you're just, all these things are happening and it's scary. And then there's different causes. So loss and trauma, isolation, loneliness, and physical health. Lately I've heard a lot about them struggling with their anxiety due to their physical health. They've been really worried about, how am I going to get to the doctor? How am I going to be able to sit here and still do what I need to do? And then the loss of even independence of even being able to leave their homes. It's been a real struggle for them. You can go to the next slide, please. So suicidal ideation kind of looks different depending on which side of the hospital we look at. So an outpatient, we're looking at, it can be passive, but they don't have any plan or intent. So they might tell us I've had some thoughts maybe in the last month, but they're not intending on taking their life. They're sitting here and they're expressing to us, I have a concern, but I don't have any means of doing anything. And I really just want to work on my depression or work on my self-esteem and figure out what is going on that it's happening. Sometimes we hear from them, I've already lived my life, I've already done everything I need to do. My life's basically over. I'm older, there's really no purpose anymore. So what's the point of continuing on? And so I kind of work with them to find a different purpose in their life and try to figure out, well, what can we do to make your life more meaningful? What is it that you're looking for? Whether that's, let's help with our grandkids or things like that. Some of them even say that they are struggling because of the physical pain and the health issues they're having. As they get older, obviously our health issues change. And so some of them really struggle with those things. And then being lonely, so their spouses maybe passed away, they don't have any family interaction. Some of them are put in homes and the families don't come see them anymore. And so they struggle with really, what does that mean? I feel I've heard a lot of, I feel like I'm in prison, I'm in jail. So where am I supposed to go now? I don't have any purpose here. So what's the point? And then some of them, it could be attention seeking. I've had a couple patients just tell me, sometimes I sit here and say things like, I wish, my family wonders why I want to be dead and everything else, just because I'll get a reaction out of them and they'll actually talk to me. And so then we have to, discuss with them, okay, well, that's not really an effective way to communicate. So what can we do to make it better? And so obviously if they're telling us like, I have a plan, and we obviously sense that they're in danger or anything like that, our main goal is to try to get them first here to the hospital and calm them down. And then we try to get them, we call it stepping up. So we try to get them to step up into inpatient services with the goal of once they leave inpatient, they can come right back to us in outpatient and continue their care with me. And so the goal is just to continue making them feel better. And you can go to the next slide.
So with mental health in older adults and the pandemic that we're experiencing currently, that brings up more questions regarding mental health and how this pandemic is affecting them. So I put the website to get specific on what Texas is wanting 65 and older to do, but the one that we really want to stress on is the social distancing aspect of it. So we find that, loneliness is a major effect for them. Their whole world has changed everything. I mean, they're shaken up at this point. So they're experiencing more loneliness at this point due to the isolation. The meaning of support system, what we mean by that is, even though like at skilled nursing facilities, they may see a doctor once a day, they may see a nurse once a day, they may see nurses multiple times a day. However, regardless of how many times they see those people, that doesn't account for their support system. They don't actually talk to those people and let them know what's bothering them or what's going on with them, and they may simply just talk about the weather or surfacey stuff. So when you talk about support system, you talk about quality of the support system, not the quantity. So increase in depression symptoms. We made a special note on there to say that the pandemic doesn't cause depression. What it can do is cause depressive symptoms. More crying. They feel sad more often. They don't want to get out of bed. Just those depressive symptoms are increasing. It's also caused increase in anxiety, the fear that they're going to, contract the virus, which, causes fear of death. The fear of being separated from their family, the ones that they're closest to. Wearing masks can be anxiety inducing. We actually asked a couple of our patients how they feel about this. And we got both sides. So one said that it makes them feel more secure when people wear masks. That means they're taking it serious. And then on the other aspect, it causes more anxiety for them because it makes it more real for them. And it is kind of anxiety inducing when you see a bunch of people wearing masks and you're the only one not doing it. It also, the isolation can increase in flashback. And what we mean by that is possible trauma that happened when they were younger or growing up or even recently. They're isolated now. They're kind of stuck in those negative thoughts and really lacking, somebody to talk to about that stuff. There's increase in substance abuse. I know we touched on this a little bit. We're seeing people using this as a coping skill. Their depression, their anxiety, they don't know what else to do. They're gonna, use alcohol or substances as a means to cope with what's going on. Decrease in sleep is a possibility when it comes to the isolation. They may lacking sleep because they're worried. They don't know what tomorrow is going to look like. They don't know when they're going to see their next family member. or it may increase in sleep. They don't have anything else to do, or they're just too sad to get out of bed. And next slide, please.
And so some stuff on the social distancing as well is, we've talked to, some of the patients we have, they come from nursing homes or they come from assisted livings. And so they're not always all at home. And so some of the things that they've also mentioned that has bothered them is that they've got a disruption in their routines. So they can't go out and do their social activities anymore. They can't have people come in and do like Bible study with them or sit here and sing to them, or even, the biggest thing they talk to us all the time about is bingo. They can't even play their bingo games anymore. And so it's been difficult for them in that they can't eat with their friends. So our patients now have told us that they're sitting in their rooms and eating by themselves. And so it's kind of an isolating thing because they don't get to even see the friends that they've made there. They don't get to watch movies or TV in their common areas because some of them don't even have TVs at their facilities, or if they do, it's maybe just one channel. And so they're really not getting to experience the different things that we do at home. And some of them have even shared that they struggle because they can't even leave to even go get their groceries and stuff because they can't go out on those outings. We even had one lady who told us that she was at a retirement community, but she couldn't even leave because they weren't letting anybody go out and do outings. And so even though she lived at home, they weren't taking anybody out to do their outings. And so it was difficult for her because she had to sit here and rely on her own family to bring things to her instead. And she really wanted to have that independence. And so, like we said, it's like a highlight of their day. They really get to enjoy being able to go out, getting to see different things, getting to do different things, and still knowing that they have that independence and they have that ability to just sit here and do something. They've even shared, like church is different. So we sometimes will ask them like, what's changed? And they share with us that they, because they don't understand technology all the time, they can't even sit here and practice all of their religions and things like that. And they can't sit here and take that opportunity to try to just sit here and connect with God the way they would like to. Their time with their family and friends is a lot different. So they can't even see their families and friends. And we'll talk about this a little bit more because we have some cases we're going to discuss with you guys that we've seen. But they can't, a lot of them said that they struggle because their friends and their family can't even come in to see them. Some facilities don't even have the opportunity for them to even Skype or do video calls like we can with their family. So they don't even get to see them. And sometimes they don't even get to talk to them if they don't even have their own phones. So it's kind of difficult for them. And then the doctor meetings. So telehealth has obviously not been our biggest fan. We can honestly say that it's been a struggle with the geriatric population. It really has. That some of them are very hesitant about even coming to group because they don't even know, what this is going to look like. Some of them, I had one today and she was super nervous about it. And she's like, I'm so depressed. I don't even get dressed or put makeup on. And now people are going to have to see me. And I was like, it's okay. You just be yourself. But they're really nervous about it because they don't understand how to work a lot of this stuff. And so trying to explain it to them has been an adventure. And so we've tried our best to even sit here and offer, if we can even get in just to show them how to do it, we'll go over ourselves and help them. So we're trying everything we can, but it's been a big headache because they're nervous about it. They don't know what this is, and it's terrifying for them. So you can go to the next slide, please.
So we're going to talk about barriers to seeking help. What we find there is a stigma behind that. We advocate, individuals getting help for when they struggle with mental hardships, all ages. I'll be the first one to say maybe you need to go talk to somebody. Everybody could benefit from some type of therapy, in my opinion. However, there seems to be a stigma behind going to see a therapist. Sometimes it's because they have a hard time admitting that there is any type of struggle, and it could be because growing up this wasn't something that they talked about. So family norms play a part of this, or it's just simply a generational thing. They just don't want to talk about it because that's what they were told not to do. Sometimes it's a personal pride. It's really hard to admit that you are struggling. We all want to portray that we're doing great and we're strong and we got everything under control, but deep down we're really not. So it could be a personal pride thing just to ask for help. And then culture also plays a part into seeking help. With my experience for all types of population, there's different cultures saying that, you're not supposed to talk about, what's going on at home or within yourself. Again, you need to portray that everything is going just fine. So culture does play a part of seeking help. Sometimes it may be because they have a hard time identifying that there is a need. Again, like I said before, some people believe that it's normal to feel sad all the time or anxious when you get older, and that's simply not the case. I don't know how many times I've had to tell an older individual that you don't have to feel sad all the time, or that it's not normal, or you can have a life where your anxiety doesn't control it. So they have a hard time identifying when there is a need. Financial constraints play a big part. Insurance, even though our patients have insurance, not all the times is help covered. And so there's an out-of-pocket cost, which, sometimes they're on a really strict budget and they don't have room for a copay or co-insurance. Also, power of attorneys play a part too. We've had a couple experiences with power of attorneys, and they really haven't bought into their family member who's older into getting therapy, which is really sad. Again, I feel like everybody could benefit from some therapy. So they may not approve of spending that money on getting help. I can't stress enough how technology plays a part in getting help these days with this virus. Yes, some of the places are opening up now, but we at Wellbridge are taking extra precautions, making sure that everybody's safe. And so technology does play a part in our treatment, and we're finding the struggles behind that. It can get confusing, it can get difficult, and that's when somebody throws their hands up and says, I don't want to do this. And then availability of services. What we mean by that is, again, like a lot of our population is in skilled nursing facilities. At this point, even though their social worker and their patient or residents ready to do this program, they may not have the technology capabilities to do it at this time. Some skilled nursing facilities, they don't have somebody that they can talk to as far as a social worker or a mental health rep, like a therapist or even psychiatrist that comes to see them. And so the availability of services are limited. And even for those that are living at home, it still plays a part. Maybe they don't have somebody that can bring them, or they still don't have the technology to do it. So services aren't available to everybody.
And something else that, for financial constraints to add to it too, is that we have to remember that some of these guys are still working. And so sometimes right now we've had some that are younger. So they're probably, I want to say in their like late 40s to early 50s. And they've shared with us that they're really struggling right now because they can't even work or find a job to continue working. And so finances are really tight for them, because they're not able to sit here and still get the money they need to work on providing even just for their family right now. And so thinking about trying to pay for their own help when they're trying to also take care of their families is a big struggle for them too. You can go to the next slide. Thank you. All right, so therapy. So I do offer so what I do here is I do group therapy. Obviously, we have 10 people usually in a group. Right now we've got about 5, maybe going on 6 to 7 next week. And so what we kind of do is we process different things in our group. So we can talk about depression, we talk about anxiety. Sometimes we do videos, sometimes I'll show them just different images. We'll do activities. Sometimes it's experiential activities. So it could be things like we bring in different like props, or I might sometimes have them bring in different things from home to discuss with us and things like that. They get homework. And then I also offer them sometimes if they really need it, or I feel like we process a difficult situation, we'll kind of do some individual afterwards. And right now what I do is I'll do group, and then I offer to call them afterwards on the video call and just talk to them one-on-one. We do have one lady that sometimes her facility's been really nice about letting us come in to see her So I go in and try to see her and check in with her. And I kind of offer that. And then I also offer for them to, if they have issues with their families they want to discuss with them, I also do family with them and let them talk to their family and know that I'm here to help them if they need it. And so some of the things I do in group with them is I provide them just some education. So sometimes they don't understand what depression is, or they don't understand what anxiety is, or even dementia and Alzheimer's. They don't know what these things are. They hear these big words and they get scared and they start thinking, oh, well, then this is what's going to happen. And I'm going to turn into this person, or I'm going to be this person, or I might hurt this person. And so I try to provide them some education on, okay, well, this is what the diagnosis looks like. And for you, so this is what it could mean. And so I kind of help them understand just what it looks like just for them. And I also help with them with coping skills. And so we try to teach each other, what do we do to cope and how do we handle this stuff? I had one lady today that sat here and I talked to her for about an hour and a half to do her assessment. And she was very confused on just depression and starting new medications and figuring out, well, what is all this supposed to mean? And what is therapy? Because she had never done therapy before. So I had to explain to her what that was. And she was like, okay, well, what does it mean to be a counselor? She didn't even know what that word meant. So I had to explain that. And so it was trying to just provide the education for her. So it kind of turned into a therapy session, but it was explaining to her everything that we do to help her. And so by doing that, she was more confident and more, willing to do the program instead of sitting here and just being like, I don't know, I'm very nervous about this. She was more willing to start. Therapy also just provides extra support and it gives support. So we, by having multiple people in here, we get to hear different stories. We get to hear different walks of life. And by doing that, they get to provide their own support to each other and learn what things may work or what things didn't or don't work. But also they get to figure out some new things that maybe they never even thought of. And so they really enjoy it. And it also just, they view it as, they'll call it like a family in here. So they view it as it's like a way for them just to come in, talk to people, get to know people, and just have a way to sit here and know that, hey, I have scheduled time to come in and actually see people 3 times a week. And I get to enjoy just having those same people coming around and I get to feel support from them. Our therapy also provides an emotional outlet. So it allows them to talk to people other than family, because sometimes it's hard. We all know it's hard to talk to our family about difficult situations and difficult things. And especially when we get older, we may not want to sit here and worry. They tell me all the time, I don't want to worry my kids about things that are going on with me. I don't want them to be worried because they have their own lives. They have their own kids. They have their jobs. I don't want them to worry about, what am I going through? What am I thinking? What's wrong with me? I want them just to live their life. And so this is a way for them to come in and talk about those things, or even when they're struggling with their families about something that maybe they're living with them and they can't talk to them about. So I provide them a way to sit here and talk about those things. And then maybe we do talk to the family or our spouse or whoever about what we're going through without them fearing that they're going to sit here and hurt them or upset them. They can sit here and find a way to communicate that to them. It provides a sense of hope as well. So by just doing this, it gives them a chance to know that things can get better. We can help you. And so even today, I said that, maybe I know Monica's listening to me. I probably said it about 10 times to just this one lady that, I can help you and I can do what I can to make this better for you, because she's expressed to me, she's really concerned about the COVID. She's really concerned of what is this looking like? And, I can't even leave my home. I can't go walk my dog. I can't do anything. So what can I do? I'm stuck at home. And so I told her, I said, well, this is an opportunity for us to just talk about things and figure out, well, what can we do at home? What can we do at our facilities to still give us some type of purpose? The need for physical touch is met. So obviously right now it's not, because we can't be in person. So usually, but when they are here, they love it because they sit here, and a lot of them will sit here and be like, can I just hold your hand, or can I give you a hug? And so they're very, can I pet the dog? Because I have a big dog that comes in and loves on them. So they're like, can I pet the dog? And so they get that opportunity to just feel comforted and loved by just another person or the dog, and just enjoying the fact that they have someone who can comfort them when they need it. And then it also gives them structure for their lives. So therapy, by doing it, they have a set plan. They have a set activity, so they know, hey, I'm supposed to go to therapy. So our therapy is Monday, Wednesday, and Friday from 10 to noon right now. So they know, okay, Monday, Wednesday, and Friday from 10 to noon, I get to go do therapy. That's my set plan for the day. And then they either call me Kaitlynn or they'll call me Miss Griffin, but they're like, she gives me homework, so I have to go do my homework. And then they know that they have their activities because we have multiple activities we do with them too. So they know that that's their set plan for the day. So without this, they're not having that set structure anymore and everything else. So this is a way to still continue to give them some sort of structure and something to look forward to, and also something to work on and something to keep their minds preoccupied without having to worry about, okay, well, COVID's still here. This is what's happening. We can focus on, well, what are the positive things that are going on in your life right now, and how can we continue to make it better? Next slide, please. So we offer, these are just some of the different types of therapy we offer here. We have art therapy. And so what that kind of looks like is this right here. So Monica, if you want to hold that one, I'll hold this one up. So this is an example of our art therapy that we do here. And so we have an art therapist, her name's Whitney. And so what she does is she comes in and she just gives them a way to communicate different things that are going on with them if they don't know how to express their emotions out loud. Sometimes when I ask them and I process with them, since I do CBT, it's harder for them because they don't always know like what they're feeling. They don't know the words they want to use. And so Whitney usually comes in and when we were in session and face-to-face, she would come in on Fridays and spend time with them and do about an hour with them. And so this was just an example of marble painting. And so what she does is she'll just have them, this one, all she did was just simply sit here and say, pick some colors and express an emotion. So this was like anger and I think peace. And so she sat here and just asked them to pick different things that they felt, pick colors, and sit here and just roll. They did marble painting, so they rolled a marble around and they got to, one, do some hands-on, but they got to let some things out as well.
Yeah, and then it gives Whitney the opportunity, like everything that she's asked them to do, she asked them to do for a specific reason. Mm-hmm. The colors they chose, the design that they made, all of that means something to her since she's the art therapist. And so again, she's able to determine kind of what's going on with them based off their art. It's really cool.
Yeah, and so her and I communicate a lot and we discuss what's going on and stuff. And so she'll ask me, what are you guys processing this week? What are you talking about? So if it's like, we're talking about grief or we're talking about depression or self-esteem or confidence or whatever we're talking about, she always pulls in something art related to go with what they've already been discussing. So it's not just out of the blue. And so they really enjoy it because they look forward to Fridays when they get to see Whitney, and they tell me all the time they love her and they really miss her right now. And they're trying, and so we still try to offer these things. We have a yoga therapist that comes in on Wednesdays. And so she'll come in, and when we were face-to-face, she would come in and just spend time doing, so instead of doing like your normal yoga, she actually does chair yoga with them. So even ones that are in a wheelchair can participate and they don't have to feel like they have to be left out. And so she'll do that, and she teaches them how do you read just your body? How do you understand your body, your body language you're projecting to other people? How do you understand your breathing? And how can you use that to relax? And how can you use these different things to cope? And so she does an hour-long session with them, and sometimes she brings in different sounds. She'll bring in different instruments, and she just she'll even ask me the same thing. What are you guys talking about? If you're talking about communication, cool. I'll teach them how to communicate with their body in a way that they understand so they can sit here and still learn how to do these different things. We do music therapy, so we still do that now. So we actually, one of our marketers, we found out that he used to be in a band and he sings. So he comes in on Fridays and he will actually sing them some songs that either he wrote or some songs that are from some of the oldies that they really enjoy. And they sit here and they sing along with them. We've watched them start dancing and just clapping, and they just love it because it's just a way to just reminisce and just enjoy being able to sit here. And after having a rough day, they tell me I make them process all the time and they get exhausted. So it's like they look forward to having that because it's like a breath of fresh air and they get to finally go into their weekend feeling relaxed and calm. And then we have pet therapy. So I have a silver lab that I bring in. She's a trained therapy dog. She comes in and she provides them with just some reminiscing. So a lot of them, every time they see her, they're like, oh, I have a dog at home, or I used to have a dog, and they call her the baby. So she's like a baby to them. And so she also sits here and she's trained just to read their emotional levels. And so she can tell when they're feeling anxious, and she can tell when they're not feeling right. And, you know, the first day the whole goal of her first day she meets them is to sit here and read their baseline, figure out, okay, so what's normal for you, what's not, and let me figure out kind of what's going on and how you're feeling. So then I can know when you're not feeling okay, let me come up and sit with you. And so usually she'll sit with them, she'll nudge on them, she'll kiss them and try to hug them and stuff like that, and try to just tell them, hey, it's okay, you know, I'm here, and let me be your support system for right now. Let me take on all your emotions. And so I still bring her in and let them see her on video because they still love to see her. And then if we can visit them, I usually will take her out with me to them so that they can see her there as well. And then we do grounding and self-soothing techniques. So sometimes we'll just do simple grounding techniques, such as like the 5 senses. So like, what are 5 things you can hear? What are 4 things you can see? 3 things you can smell? 2 things you can, you know, you get the gist. So it's like, we just go down the whole thing and we'll just sit here and do that. Sometimes I use a simple like touch method. So I'll just like touch their shoulder and say like, hey, I just want to make sure you're okay, and things like that, just because, you know, sometimes they get triggered by different things. And so we want to provide them with that opportunity to learn how to ground ourselves and get back to this. We're in a safe space. This is your safe space, and it's okay. And sometimes we have to also teach them those soothing techniques because when they go home, you know, they have to be able to implement these things. And so I know a lot of them, just by doing that, they've told me that, you know, they've even taught their significant others or family members, hey, this is how you can help me. And so they're actually teaching somebody else how to help them. Next slide, please.
Medication management. So we do therapy as well as medication management here if they ask for it. My biggest saying is medication isn't the end all be all. I don't believe that medication is a cure. However, I do feel like if it's paired with therapy, it can really be successful. Medication can relieve mood disorder symptoms in a timely manner, meaning most medications patients start feeling better within a couple weeks. And then, so like I said, it relieves mood disorder symptoms, you know, fairly quickly. So they're able to concentrate and participate in group more effectively. Pharmacogenetic testing. Yes, it took me some time to really learn how to say that. But it takes a trial and error out of medication management. What we find when I think at any age, after, you know, testing medications and finding that it doesn't work, the more and more you try it and it's not working, the more you probably won't take medication. And so we offer pharmacogenetic testing to take the trial and error out of the medication management. So the doctor will choose medication based off what genetically works best for that patient. So it's pretty cool. Medication gives, you know, people peace of mind, whether it's the patient themselves or their caregivers. It gives them that sense that they're going to start feeling better quicker rather than later. It relieves some of the symptoms for the caregivers. So when the patient's feeling better, the caregiver's world really changes better. So it just gives a peace of mind. Again, it's not the end all be all. I really believe when it comes to mental health, therapy really helps, and it's even more successful with medication management.
And so we actually have a psychiatrist here on staff with us that when they start the program with us here, we actually have the nurse practitioner. We always explain to them that the nurse practitioner will come in and see them. Usually while they're in group with me, we'll have the nurse practitioner just call them into a different video chat, and they'll talk with them one-on-one, and they do a psych eval with them. And they understand they do not have to get meds from us here with our program. They don't have to do it, it's voluntary, but they really enjoy knowing that they have that option. Or if they come from inpatient to come down to us, they really like the fact that they can continue seeing our psychiatrists and stuff, because it's already something that they know and they've already established. And so they get that opportunity to still continue the medication management with her, and they really enjoy that. So that's something we do offer here. Next slide, please. So pros and cons to our telehealth and video conferencing. So some of the pros we have is that it still provides treatment without risk of exposure to the virus. Now, it still gives them a sense of support, like I said, so it still allows us to give them, you know, mental health support. It still allows us to give them counseling. to even show them like, hey, we're still here for you guys. I know that they sat here in the moment that we said, hey, we couldn't, unfortunately we have to stop IOP face-to-face for a little bit. They were pretty bummed. And so Monica and I were just like, okay, we've got to figure out a way to still do IOP for them because they really want to be able to sit here and still get therapy and things like that. And so 3 days later, we're like, let's do telehealth. And we threw it all together and we started it. And the moment that they saw Monica and I's face, they were so excited because they're like, we can still see you. And that's all that matters. And they can see each other. So they were just beyond excited just to still be able to see each other, even though they weren't in person. It still gives them purpose. So it still gives them something to do. It still makes them feel like that they're, they're cared for, that they're important. And it still, provides them with something to do daily. Like I said, that schedule is very important to them and having the structure is very important. So being able to know like, hey, I still have an obligation to make it to something 3 times a week is better than sitting here and just sitting at home saying, there's nothing for me to do. They still have an opportunity to visually see each other. I mean, sometimes, yes, we have to deal with internet issues and things like that, but we always make it work. And so they still get to see each other. They still get to be able to see each other's faces, see what's going on, see if somebody's upset or if somebody's happy and enjoying their jokes, and still get to be able to make that face-to-name connection. They still get to meet new people. So by doing this, they might get to meet people that are even further away from them because, we put on here that geographical location doesn't factor. Now, when we did face-to-face, it did because we had to watch our radius and things like that because while we do provide transportation, we can only go so far. And so by doing it this way, now we can pull in different people and be able to not have to worry about, okay, well, where are you located? How far away? Can you drive or do we need to pick you up? How are we going to figure out transportation? We don't have to worry about all that stuff. They can just come in and all talk to each other and be in different places. And then it allows for even people who are physically homebound. So the ones that might sit here and be like, well, I can't really leave my home because maybe I've got all these medical issues or anything like that. They can still participate and still have a way to get therapy. They can still talk to somebody without having to worry about having to leave their home and stress about how are they going to take care of themselves. Even like if they have wound care or anything like that, they can still be at home. Some of the negatives, it's obviously dependent on internet connection. I mean, we've experienced that quite a bit with, the different devices. So we try to encourage them to use like tablets and laptops, but that's not always the case. And sometimes we have to sit here and accommodate. So there might be times that I sit here and I have some on a computer and I have some on FaceTime, and we're just trying to make it all work so that they can still at least all hear each other and talk to each other and know they're all still here. Technology can be confusing for them. We've had some of them when we sat here and mentioned, okay, well, we're going to do telehealth. The first thing they said is, well, I don't know how to do any of that stuff. I don't know how to download anything. I don't know how to sit here and work my phone. I don't know how to sit here and even get into the internet. And so it's a difficult thing for them to do. Or even if we mentioned, do you have a smartphone? They don't know what that means. They're like, what is that? And so we have to then start trying to rely on other people to sit here and help set that up for them. And it's not always easy because they don't know what that means. And then some of them don't even want to be involved. Like their families don't want to help and they're not even at home. So it's just a big constraint. So another negative is that I lose the ability to sit here and read their body language. So sometimes I'm not, yes, I can see their face and I can usually see their upper body, but I don't get to see if their legs are fidgeting and they're really anxious and they're masking it from me, or what else is going on, because I only get to see what they show me on the camera. So it's a lot more difficult because I don't get to sit here and really gauge what's going on, but I can only do the best I can. And then they also, like I said, lose that physical support because, they like to hug each other. They like to hold each other's hands. And so by not being able to do that, they're losing that ability to just have somebody give them a moment of physical touch to tell them like, hey, it's okay. And I'm here for you without having to express that. Next slide, please. And so I'm just going to kind of talk about briefly just some of the cases that we have here or that have recently discharged. All these cases were here before COVID started, and some of them are still here during it right now. The first one is a 6-year-old female. She came in for trauma. So she had a lot of sexual abuse that had happened when it was about maybe 15 years of sexual abuse. She had some grief. So her best friend had just died. in October from suicide, and she was really taking that in pretty hard because that was her only support system she had. She really struggled with trying to figure out, how do I cope with this? And she put a lot of blame on herself as well, because she felt like it was her fault that she hadn't noticed the signs that he was suicidal or anything like that. So she really struggled with what do I do? And then she had a lot of issues with relationships as well. Her husband, she sat here and told me her husband is not a support system for her. She only married him because she truly identified as a lesbian, but she wanted to sit here and didn't want anybody to know in her family. So she married him just to kind of mask that. And so she really struggled with being in a relationship with him, and with all of her trauma and stuff, she really struggled with trying to talk to him and convey what she was feeling to him. So she felt alone at home. And so when I started working with her, the first day I talked to her, she was just really upset. She started crying, and it was just 2 hours of crying. And she just really had a rough time because she didn't know how to sit here and tell anybody, hey, I'm really struggling with this stuff. And she had really bad experiences with therapists before, because anytime she told anybody what had happened to her with her abuse or anything like that, the therapist would sit here and like shut her out, and they would stop working with her because they couldn't handle what she was talking about. And so she was really nervous about even coming to group, because she was afraid that the people in group were going to be scared of her and what she went through. So she did come to group, and she was here, I want to say 3 months, maybe about 2 to 3 months, and she worked with us. She didn't have any connection to her kids. She wasn't going to talk to them. They both blamed her for a lot of the things that had happened in their life. She found support within the group. She actually had one person that she really felt supported by, and she really struggled because that group member had recently passed away. And so that was really hard for her as well, to kind of understand that, that group member was gone. She was willing to work on a whole bunch of stuff. The moment she came in, she talked about everything. She sat here and told us that, but after that group member died, she told us, I don't know if I can sit here and trust anybody anymore, because everybody I talk to, they leave. And so she recently discharged. She was doing really well. She was actually finally had boosted her confidence. Her self-esteem went up pretty good. When I asked her, how are you doing about being at home with the COVID stuff? She said, it's just like in my normal life, because I isolated a lot before this, and I isolate a lot now, but it's due to her medical issues. She's got fungal pneumonia and everything else. So she's like, I can't leave already. So it's kind of like, for me, being at home is kind of a blessing, because I don't have to sit here and feel like I have to leave. But she did share that she missed being able to come to group and see everybody. She missed being able to just be here, because this was her one opportunity to have a reason to leave home and actually do something that wasn't involving having to just sit at home and stare at a wall. And so she told me she found different things she could do at home and things like that. And I asked her, once they discharge, we usually give them referrals and say like, hey, here's ways you can go talk to some individual therapists so you can continue your care. And I asked her how that was going. And she said that she's like, honestly, she's like, I'm not ready to start all over again with anybody else, because I don't want to have to talk about everything, because I'm still afraid that if I go to talk to a new therapist again, they're going to sit here and be terrified of what I have to say. So she still has that thought in her mind, but she said she's going to take her time and she's going to find someone that's right for her. But she really appreciated being able to work with the group that she had and being able to be there with everybody. The next one more. I think we're running out of time. Yeah. So we'll talk about, we can go ahead and talk about the 66-year-old female with depression and substance abuse as well. So she came in and she had just left rehab for drinking. She was very depressed. She was very upset. And she shared with us that she had some trauma actually from her rehab with one of the nurses. She said she felt very uncomfortable with him and that he favoritized her and everything else. So she was really struggling with him. And so she had actually she told us about the COVID. She was really anxious about having to watch the news and seeing it. She was really struggling with the isolation, not being able to see her family, not being able to sit here and talk to anybody. We found out from the family, she had recently passed about 3 weeks ago. Mm-hmm. She passed away about 3 weeks ago. And it was just due to some health issues. However, she sat here and kept telling us, you know, like, I'm doing fine, I'm not drinking, I have cravings once in a while, but it's not bad or anything like that. And so when the sister had called me, she informed me that that wasn't the case. She actually had started heavily drinking again due to the COVID and her anxiety and things like that. And they noticed that she was drinking a lot more. Her anxiety was really high. So she was just having a really rough time with this and not being able to see her family. And so, you know, the important thing is that we just want to remember that this is still causing them to struggle. It's still causing them to feel anxiety, and it's still causing them to, you know, struggle with finding ways to cope with it. Next slide, please.
So to wrap everything up, I think we really want to stress that mental health doesn't discriminate against age, gender, ethnicity, socioeconomic status, or the living facilities. You know, individuals are living longer and the population is going to grow. We're only going to get older, and older adults are only going to grow our population. But that doesn't mean the mental health struggles are going to stop. You know, it's not normal for older individuals to have depression or anxiety. You know, older individuals can have a really good quality of life, you know, and so we should be able to offer them treatment just like anybody else because they need it. So with the COVID or the COVID pandemic right now, it is ideal for our older population to be isolated, but we have to remember that that isolation is going or could possibly cause some mental health struggles, and we need to be able to help them, you know, get through that. So I think at this point we're going to open up to see if anybody has questions, if they need us to explain anything. So just, I think we have to use the question and answer forum. So if you guys have any questions, please go ahead and ask. We'd love to answer some.
Well, everyone is typing in their questions. We are going to use the Q&A. I did have a question emailed to me earlier this week. This topic has been on people's minds, and people are really interested in it. So this question comes from David Barnes, and his question is, how, I guess I need to read more about it, but it's all about loneliness and seclusion for people in senior living as well as the staff. And his question is, how can he support them, the residents, but also the staff, directors, etc., and what can we actively do to aid in this concern?
So I would recommend, obviously, just, you know, while they're still isolating, you know, what we've noticed is that we tell the staff, like, hey, you know, if you guys even just, you know, need us to talk to you, we just keep talking to them, keep telling them, you know, that you understand, try to, you know, just help them as much as they can and just be there for them. Sometimes the best way to just sit here and show compassion to someone or show that you care is just to sit there and just be there and listen to them without trying to understand what's going on. Even the residents, we sit here and, you know, even just telling them, like, hey, you know, trying to sit here and if you can, like we do, we're trying to, if we can even go in and just see them, great. I mean, we had one that we sat here and they said that they're even trying to accommodate now that they let the family and them come to see her at her window outside, and they talk through the screen window, but they still can at least come in and talk to her. So just sometimes just being there and listening and just trying to tell them, you know, we're trying to define creative ways to make it work.
Yeah, I think at this point we just have to be creative. You know, going out of your way to talk to somebody, say hi to them, it goes a long way these days for those that are in facilities. Always keep in mind for those that are working in the facilities, you know, their residents are in the rooms by themselves for majority of the day. I think most of them allow the residents to come out and walk around for a little bit. But even that's minimal, and they're still not getting that socialization aspect that they're craving. So I think at this point, it's just getting creative, going out of your way to say hello or to go check on somebody goes a long ways these days.
We did have a couple of other questions from some of our participants that they've put in the Q&A. One of them is about resources for those people who either don't have insurance, don't have funding, or maybe who don't have money for their copay. What do you recommend?
I think support groups at this point. A lot of support groups, they don't require any financial aspects of it, so support groups would be great at this point.
And is that something they can call you and get a referral for a support group, maybe that is related to their situation, or when we get out and be together again, something that would be nearer to their neighborhood?
Yeah, we are willing to help with referrals and ask, if anybody, and I've always told people that if you have questions or concerns, ask us. If we don't know anything right off the top of our head, we'll do the research and we'll look it up for them.
I mean, I've had families come and just ask me simply like, hey, I don't know. So like we just had one that got diagnosed with Alzheimer's. I don't know what that is. And so I sat here and sent them books, articles, activities. I mean, we are willing to do anything we can. If we have to sit here and find you a support group that is, is at a sliding scale, we're going to sit here and help you figure out where you can go. So we'll definitely do what we can.
That's great. And do you encourage like professionals, like if I'm at a community and I have a resident who could benefit maybe from a support group, I could give you a call, or would you recommend me having the resident or the individual call themselves?
So what we usually do is we usually tell them how our referral process works is we'll tell the facility, hey, go ahead, and usually what we'll ask them to do is all we ask is you send over clinical, you send over a face sheet, and you send over a med list. It'll be e-faxed over to our intake department. The intake department will forward it to us, and then we'll call and we'll simply just tell them like, hey, we got the referral. When can we talk to the individual? And we will actually reach out to the individual. If they say, hey, well, they have a cell phone, you can call them on that. Cool. Then we're going to call them and we'll explain to them, okay, well, here's what we do in ILP. Here's what it looks like. And so either Monica or I will call them, introduce ourselves, and tell them. If it's face-to-face, what we do is when we go back to face-to-face, we actually drive out to the facility or we drive out to their home and do the assessment. So we'll go meet them in person. But right now, since we're doing telehealth, we'll call them on a video and say, this is who we are. If Monica or I is doing a satellite, we'll call in together and still so they can see both of us and talk to us. And we still do everything that way. And we'll just explain everything to them. And if they're interested and ready to go, we'll get them usually started like the next day that we can do group. So
that's great. That's pretty quick. Kathleen?
Yeah, I mean, we try to do it as quick as they want to do it. We'll get them in.
Kathleen, do you have more questions, or should I continue with the ones I've got?
You should continue with the ones you've got. Because I can see them. There's a lot.
Another person has asked, whose pharmacogenetic system do you use?
So again, it's taken me some time to be able to pronounce this.
Did I do okay? Did I say it right?
Yeah, almost.
You did a great job.
It's pharmacogenetic, and we use GeneSight. So we use the company GeneSight. So before the COVID pandemic, it was all done. It's all done in-house. We swab, we get the doctor's signature, we send it off. And it's about, I think he said about a 72-hour process. And so like from start to finish, they'll get their results within the next 3 or 4 days. Now with the COVID pandemic, how that works is we will still order the test gets shipped to their home directly. They swab, it comes instructions, it comes with a prepaid FedEx, they just have to do their swab and then send it back. But it's very simple. I think they test for like 52 genetic genes and all that stuff. It's really cool.
Yeah,
so we use GeneSight.
It's pretty simple. It's just packet and it's got the swab and everything in there. They fill out the order, they put the swab in here and send it off.
Yeah. They can still do it through this COVID pandemic.
Yep, and so we just order it and send it to their home and they do it there.
Great. There was another question about the examples that you used, and it seemed like you referred only to female clients. Do you have males in your groups? Do you segregate groups? What is the composition there?
No, so yes, we have males in our group. Honestly, there's not a lot. We haven't had a lot. The reason we chose those were because of their situation. And
in the relation to COVID. We did have one it's usually we have maybe one guy to like 6 females. And so he's like the only guy in there hanging out with all these ladies. I mean, they usually get all the attention. So
Right.
we do.
but he does, so a little bit on him. He's younger, he's about 40, I think he's 47. He is struggling too with the COVID stuff a little bit. He finally opened up about it, and we've been working with him for a little bit. Finally opened up and said that he's really struggling. He does have PTSD. He did serve, so he's really struggling because he's noticing a lot of sporting goods stores are just simply sitting here and saying, hey, well, we're out of guns and ammo right now. And it's terrifying him because he's like, honestly, I'm more terrified of that and everything else. And he's told me I'm more terrified of COVID and everything else that's happening than I was serving and having a missile shot at me. And I was like, okay. So that's about, he's still very closed off. He doesn't share a lot of his emotions, but he's told us before he's more terrified about the fact that people are buying a lot of guns and ammo to protect their homes. And that's more terrifying to him.
Yeah. It sounds like he probably likes to be a little bit more in control of situations. And I know we've all been feeling very out of control with the pandemic and not knowing when it will end and how it will continue and whatnot. I do have a few more questions. One was about how are your staff maintaining their mental health and you maintaining your mental health as you're also coping with COVID and the pandemic and all the changes we've having, but then also kind of your compassion fatigue with working with these clients who've experienced trauma. So what are you doing that's helpful as professionals?
So being there for each other is the biggest one.
So we have a really good support. Our team is a really close-knit team. I think that's super important when you work in mental health, that you feel like you have somebody within your team that you can go to and talk to. And then for a personal thing, like, I have always stressed that for me, when work gets tough, your home life is super important. Like, your home is supposed to be your safe place. And when you work in this field, you want a home that you feel safe, that you can go to and relax. And you have to be able to separate home and work as well. So you have to really work on that. But as far as working in this profession, I can't stress enough the importance of having a really good team. Somebody, at least one person in your team that you feel comfortable. Because we work really close. Obviously, we're really close. But you
are not 6 feet apart.
No.
I mean, we work in the same office. We're like, it's not even like we're colleagues. I view like we're more like friends. So we talk to each other about everything.
Yeah. So you just, to keep our mental health, we rely on each other. I rely on my home life. And, I can't stress enough how I feel like everybody could benefit from some therapy, even if you are not getting what you need at home, you're not getting what you need at work. And if you need to call us and say, hey, can I have referrals from individual therapists, by all means, call us. I can't stress that enough. Look for somebody that you can go and talk to.
Yeah. And I mean, like I tell them all the time, the best therapists have their own therapist. Just, talk to somebody. And I know, like, I recently had to go home and quarantine for a month because my husband got sick and then I got sick. And so it was very difficult for me. And I've told my patients, I understand. I struggle with depression and anxiety too. I get it. It's hard. And so the first thing she said to me is, what can I do to help you? And I said, just message me once a day and ask me how I'm doing. And that's all I need. And so sometimes it's just the small things of sitting here and just asking somebody for help is the biggest thing that you can do too, is tell somebody else what you're going to need. If you need something, that's what we like about here is here we can ask each other, we simply just ask each other, what do you need? And we will help. It does not matter what department you're in. If we don't know how to do it, we're going to figure out how to do it to help you. So we help each other as much as we can.
Oh, that's great. That's great. We all need somebody we can vent to and who can really get us. I have 2 more questions. One is, what would you recommend for a daughter and wife currently dealing with a father who's struggling with increasing dementia issues? They're scared to approach him because his reactions are turning more verbally abusive and hard to deal with, and things have gotten a lot worse since the COVID-19 pandemic.
So I guess first step would be, obviously, we would recommend for daughter and wife to find some support and get some help.
Yeah.
It is not easy. We unfortunately just had to kind of, like I said, we had to go break the news about a week and a half ago to a patient and tell her, well, we found out you have Alzheimer's. And that was not easy for us to do because, I mean, obviously the daughters relied on us to do it. So already we were put into a predicament because we're like, oh, okay. But we had to sit here and go and, you know, be that one, we had to be that support system for her to explain to her, like, this is what Alzheimer's is. This was what it looks like. It's not, you know, as bad as it sounds and stuff like that. But we also had to be the people that got the basically the bearing and sit here and got the anger taken out too, that she was not too happy about it at first. And so unfortunately, Monica had to do that part. But, you know, we had to sit here and we had, you know, I would recommend first get some support and talk to somebody about it and figure out how you can convey these things to him, because it's going to be hard, especially to hear like, hey, you've got you've got memory issues, you've got dementia, you've got Alzheimer's, because the first thing they're going to think is that there's something worse than it is. And it's easier to figure out how do we tell them that first and explain it to them, and what do we know about it, so then we can teach them what that actually means.
So yes, so I think the daughter and the wife need to get some support system, whether they need to seek help as far as therapy and stuff. However, as far as their father goes, what concerns me is the aggression. And so I recommend giving Wellbridge a call and see what we can do to help as far as the dad goes. Now with dementia, there really isn't a whole lot of medication that can help. There might be some other things going on medically that could be causing these symptoms as well. I'm not sure if they've been formally diagnosed with dementia, but if they haven't, then I would recommend calling Wellbridge to kind of go through the process to see kind of what's going on. Again, the aggression is very concerning because it probably is going to get worse, and it's not going to be a safe space for daughter and wife. So again, the daughter and wife, I would recommend seeking a support system, because, you know, the dementia is not going to go away. It's only going to get worse. And as far as the father goes, I would call Wellbridge or a behavioral health hospital to kind of see if we can get that aggression kind of under control, and then form a game plan for safety reasons for the father and safety reasons for the daughter and the wife.
And Wellbridge, here at Wellbridge, we also we have discharge planners who work on helping with, if they need to go into like a memory care or something like that, they will help set that
Memory
up,
care,
get them
home
situated,
health.
And we will actually, if we have to help, we can actually transport them to their new facility and things like that too. So we help with getting all that set up for them.
Okay, good to know. And I think probably the Alzheimer's Association would be a good resource too for support groups and maybe even suggestions for interacting with the husband / dad.
Yep.
Okay, I'm seeing one more question in, Matt says thanks, you're welcome. The last question that I have is, after these experiences that you've had with the COVID-19 quarantine, not being able to see patients in person, learning all these new ways to think about and do therapy, what, when we go back to normal, whatever that looks like in the future, what do you want to keep? What are some good things that have come out of what you've learned and things that you might carry forward into the future?
Well, we've talked about maybe potentially looking at, we'll have face-to-face, but maybe spanning it out and letting because we have some people sit here and say, well, I can't come and commit to group, because when we're in face-to-face, group is not from 10 to noon, group is from 10 to 2. So it's longer because we offer them lunch here. So they come and do one group, they have lunch, and then they do 2 groups after. So it's a little bit longer. And so we looked at maybe potentially asking about offering, maybe we do telehealth in a different group, and we sit here and have, the younger individuals who can handle this and are working We do it that way. We do like a telehealth group and a group that's in person. We've looked at different options. Obviously, we're going to take away the experiences from it, teach them, I've learned different ways to change my group and make it work. So even if that's like, we need to change activities, we can do it that way. I've learned that they like, I made them all a workbook for us to do. So even the workbook's been helpful. So maybe we'll keep doing that even in person, because they really like having the workbook, and it's just, a bunch of stuff for them. But so there's different things that I've taken away, and like even coping skills. So there's different, new coping skills that they've even taught me that I didn't even think of. And so I'm like, okay,
we're all learning.
I love it when they teach me new things instead of me teaching them. So it's kind of cool to sit here and be able to take their stuff and be able to, now when we go back to whatever normal is going to be anymore, we can sit here and I can continue to use that with them and teach them different things.
Right.
Yeah, I think for me, what I would like to do and what I want to keep is opening up our group, the age range. We specialize in the older population that's what we do. We're very passionate about serving the older population, but I would like to expand it a little bit more, just to provide more. I think even the population that's, close to their 40s and mid 40s, I feel like they respond really well for our population and the older adults, because we talk about some really serious, life-changing situations. Not saying that, 19-year-olds or 20-year-olds don't have serious things going on. However, what our older population is experiencing is quite different than theirs. And I feel like they're capable of relating better, and they provide, really good services for each other. So I would like for us to expand our age range just a little bit.
Great. You might have to rename those of us who are 40 and 50. I don't know if you love being called older yet.
Well, hey, we're
older is always supposed to be 20 years older than what you are. So
we sell it. Right now we have one that's 36 coming into the program. We're like, okay, are you okay with people who are maybe just a little bit older than you? They're like, that's fine, we don't care. And I'm like, all right, well, welcome to the group then.
I just think that the conversations are a little more deeper and a little more relatable towards the older side generation. So
yeah. Well, so great. Those were all my questions I had. So I'll turn it back to Kathleen.
All right, we have one last question. This will be our last question because we are out of time. But this question is, what do you recommend for someone trying to get long distance help for a mentally ill female, 60 years old? The family lives in a different state with possible paranoia disorder, who absolutely refuses to believe anything is wrong with her. She's been in and out of mental health hospitals with involuntary committals for 3 years. She refuses medication, thinks her family is conspiring to ruin her life, and they caused all of what has happened to her. There's no talking any sense into her, and she believes COVID is a hoax and businesses are locking her out and only locking out her.
Yeah. Okay. So this is obviously a really tough situation because, you're essentially asking, what do we do for somebody that doesn't want anything to be done for them? And so you kind of really have to take that stance. At some point we have to decide and let ourselves know there's only so much we can do. You cannot make her do anything. You can't force her to do anything if she doesn't want to do it. And so my recommendation is to kind of, if she doesn't want the help and she's not willing it, if she thinks everything is fine there's not a lot you can do.
We just recently went through this with one of a patient of our own that sat here and believed that it was everybody else and it wasn't her fault, that it was her family's fault and everything else. And so we had to come to that realization ourselves that, what, we can only do so much, but they also have to want to get the help and they have to want to change. So as much as, we want to help them and we want to make it better, they have to want that too.
And I think, yes, you can only provide so much support, but when it gets to a point to where it's their safety that is if it's a matter of safety issue, they need to call the appropriate authorities, call 911, and go from there to make sure that their family member is safe. But if they want to live in this reality and there's nothing that you can change it, then there's nothing you can do about that. But ultimately, you want to make sure that they're safe, and if they're not, you need to call 911.
Awesome. Well, thank you, ladies. We so appreciate you being on today. And thank you to Wellbridge Healthcare for hosting and for inviting you to speak to us today.
Thank you guys so much for having us.
Yes, thank you.
Thank you. And thank you, Christy.
Thank y'all.
So now that concludes our educational program for today. In order to get your continuing education certificate, there will be a survey that will pop on your screen at the end of the seminar today. So you do have to complete the survey. When we get those survey results back, you'll indicate whether or not you need a CEU certificate. If you do, you need to make sure that you put your email address and your date of birth, not your year, but month and day, in the survey in order to receive your certificate. And we'll be matching up the surveys that we receive with the attendance today. And then also want to let you know that next month our DAGS event will be virtual again. It will be same time, same place via Zoom, and it'll start around 3 o'clock. And we will be sending invites out to that. You'll also be able to find it on our Facebook page and on the DAGS website starting June 1st. So look for that. Also want to share another educational program that is coming up on June 2nd. It is actually hosted by CareWorks and Seniors Blue Book. It'll be June 2nd at noon. There'll be CEs offered for nurses and for social workers. And it is on opportunities for connection during isolation. It's going to be done in conjunction with CeCe Young, and Haley Mosley is the speaker for that, and she is the president of the Activity Professionals Association, and they are seeing some really great positive outcomes coming from some changes that they've made in the activities that they've been doing with their seniors over there at CeCe Young. And so if you are interested in learning more about that, that'll be going out next week. And so if you don't see it on Facebook or if you don't see it on Seniors Blue Book, just email me and I'll make sure that you get the invite to that. And so that concludes today's program. So thank you all for being here. Don't forget to do your surveys, and we'll see you next month. Thank you.